Now, here to expand on these ovarian cancer abstracts that are being presented at the meeting is Dr. Kathleen Moore, who is an associate professor at the Stevenson Cancer Center at the University of Oklahoma. Hello, Dr. Moore.
Hello.
Thank you so much for being here.
Thank you for having me. Happy to be here.
Great. So let's dive right into these ESMO 2018 abstracts that you're on, starting with the SOLO-1 trial. So can you give some background on SOLO-1 and what is being presented here at the meeting and what's really important about the findings here?
Absolutely. SOLO-1, I have the privilege of presenting, but it was a very big team, international team effort. So SOLO-1 really addresses what is one of the biggest problems in advanced ovarian cancer, and that is that we just still have a highly treatable disease, but a disease that doesn't have very many women who live disease-free long-term. So our cure rates are very low. They're dismal, in fact, about 10 to 15%. And really the only way we're going to impact on that is if we improve frontline therapies. So SOLO-1, and there's been a lot of effort to do that over the years in many different trials of kind of all-comer populations with, really no impact on overall survival, but some incremental improvement in the progression-free survival. So we have made a dent in it, but we really haven't, since the kind of discovery of platinum, really markedly improved disease-free survival. So SOLO-1 really seeks to show that we can do that. So it's a randomized phase 3 trial for patients with advanced stage ovary cancer who also harbor a BRCA mutation. And they received standard of care chemotherapy, and they had to be in either complete or partial response to that chemotherapy. They had to have had an attempt at a cytoreductive surgery. They had to have been in excellent performance status. And then if they met all those criteria and enrolled, they were randomized to receive olaparib tablets, 300 milligrams twice a day, or placebo. And that treatment was continued until disease progression, or if patients were disease-free at 2 years, they were stopped, unless they had come on to study with a partial response and still had evidence of disease at that 2-year mark, but it was stable. And then they had the option of continuing with discussion of the PI and the medical monitor. So that was the design. The endpoint, primary endpoint is progression-free survival as assessed by the investigator. And it was measured from the time of randomization, so end of chemotherapy. So that's different than most studies, until such time as patients recurred or we reached the data cut point and they're censored at that point. That's a good problem to have. And then there were a number of secondary endpoints that are very important, one of which is progression-free survival is assessed by a blinded central review. One of which is PFS2, which is the time from randomization until the second recurrence among those patients who recur. And that's a very important endpoint, especially in the EU, where it's a regulatory endpoint because it's felt to maybe recapitulate what you would see in overall survival.
Okay.
And then we had quality of life endpoints. So the patients that were enrolled on SOLO-1, the women who were enrolled, were of excellent prognostic factors. Again, a population unlike any that's being recruited into current frontline studies, which are kind of trying to get these high-risk patients. These were women with BRCA mutations. They were thereby a little younger. They had excellent performance status. Over 60% of them had a frontline surgery, and of those, 75% were debulked to no gross residual. 80% of them entered the study with complete clinical responses. So these are your responders. And then they were randomized. In the group of women who received placebo, the median progression-free survival for them is 13.6 months, measured from the end of chemotherapy. In the group of women who are randomized to olaparib, we have not reached the median progression-free survival yet. So they are doing remarkably well.
Yeah.
The difference in the survival curves, if you look at kind of the area under the curve difference, gives us a hazard ratio of 0.3, which really translates into a 70% reduction in the risk of recurrence with use of olaparib. And even though we haven't met the median for the olaparib group, there were a number of what we call sensitivity analyses done that account for the potential of bias to try and just make sure that we are very confident in the hazard ratio estimate as assessed by the investigators. And all of those were very consistent. But 2 of them did give us an estimate of the median for that group, and so it's 46 to 49 months.
Wow.
So we can estimate that the improvement in progression-free survival over placebo alone is about 3 years. Progression-free survival was also still statistically significantly superior among those patients who did recur and had received olaparib frontline. So these are really, I think, unprecedented results in frontline ovarian cancer. We hope that it translates to more women remaining disease-free long-term. We use the cure term. Are we curing more patients? Can't say that yet. And we're going to have to follow these patients for years because they do very well. And we're going to do that. We're going to keep a close eye on them as long as it takes. But I think the early indications are that we've really done something. These women who participated have done something really unprecedented in ovary cancer, so should result in a very rapid change in the standard of care.
Wow, it's really, really exciting news.
Yeah, it's very exciting. It's exciting to be able to tell people today.
Yes, of course, yes. Yeah. All right, so now we're going to switch gears a little bit and go into a different PARP inhibitor, the Quadra study. Mm-hmm. So what is a little bit of background on that study, and if you can share insight on those results?
Sure, so niraparib is a different PARP inhibitor than we previously discussed. It's, I think the PARP inhibitors are more similar than they are different, but one of the key differences of niraparib is that it's once daily dosing, which is nice. And niraparib was actually the first PARP inhibitor to gain U.S. approval anyway in the maintenance setting in recurrent disease. And so we do have a lot of experience with niraparib in that group of patients who are platinum sensitive. They respond again to platinum, so good prognostic group of patients, and then they are placed on niraparib maintenance. And so the maintenance setting, I think we've pretty definitively shown with niraparib, olaparib, rucaparib that there's benefit across all subgroups, which is why you have approvals regardless of biomarker really for any of those in the platinum sensitive recurrent maintenance setting. I think one of the questions that we still have that are really we won't know the answer to pending results is, do you need that induction chemotherapy and then maintenance, or can you just use a PARP inhibitor as treatment? And is that equivalent in a platinum sensitive setting? And then, how efficacious is a single agent PARP inhibitor in a platinum resistant patient with a BRCA mutation, with HRD, or with neither? And so there've been quite a bit of studies in that platinum sensitive, Ariel 2 was there. Olaparib, study 42, had both platinum resistant and platinum sensitive. Niraparib really, with the Quadra study, sought to evaluate use of a single agent PARP inhibitor in really a difficult to treat population. So they're looking at heavily pretreated patients. So you had to have had at least 3 lines of chemotherapy to come on olaparib. They allowed, the primary endpoint for Quadra was looking at patients who are sensitive to the last platinum. They didn't have to have had a platinum in the last line, but their last platinum they were still sensitive to, positive HRD, and looking at efficacy. But then they wanted to look at platinum-resistant disease in BRCA patients and HRD patients and biomarker negative. So it really wanted to look across the board at all subgroups of patients to sort of see what the potential benefit of niraparib could be. Because there's a lot of patients that don't fall into the current indication for use of olaparib, which is germline BRCA and at least 3 lines of chemo in the US, or rucaparib, which is germline or somatic BRCA and 2 lines. Right. So if you just have HRD or you have had 2 lines or you're platinum resistant, you can't access a PARP inhibitor at this point. Right. So Quadra was the largest really single agent PARP study to date. It's 463 patients. Wow. And the key endpoint, which was platinum sensitive, HRD positive, we had a response rate of 27% and 4 or 5 lines of therapy. So heavily pretreated, not necessarily BRCA positive. And then in subgroups, you didn't see a high response rate, but you did see a lot of disease stabilization out to 6 months. And so when you're in 4th line or 5th line, and you're using an oral therapy for platinum-resistant disease, and you have someone go 6 months, 25% of the time, that's a meaningful clinical endpoint for patients. It's a hard regulatory endpoint, so it's hard to really argue that as a means to approve something, although I hope we can. But it's a meaningful clinical endpoint to patients. So Quadra really gives us a sense of what kind of clinical benefit can be seen beyond just I can shrink your tumor 30%. And here at ESMO, we just updated the ASCO presentation from earlier this year to really focus on just the BRCA patients. Again, just to show appropriately, the emphasis has been on getting PARP inhibitors as early as possible, and now frontline, to patients with BRCA mutations, because we know they work best. But there's a lot of patients out there who are long-term survivors who are in their 4th or 5th or 6th line of therapy with BRCA mutations. So this data really shows that the efficacy doesn't stop, right. And that those patients still would benefit potentially from use of a PARP inhibitor, and so we should keep that kind of on their list of therapy. So this was really an update of just the BRCA patients, but in a slightly different population that I think has been emphasized in the past.
Definitely. Wow, that's great. Now, there's the phase 3 ENGOT GCIG intergroup study of carboplatin, pegylated liposomal doxorubicin, and bevacizumab versus carboplatin, gemcitabine, and bevacizumab in patients with recurrent ovarian cancer. So what is the rationale for this study and what were the findings?
So this is a great study, because this is a study that medical oncologists and GYN oncologists take care of ovary patients. We think about this almost every week, like when we're making a decision. When you have a patient with platinum-sensitive recurrent disease, there's the 3 doublets. There's carbotaxol, carbogemcitabine, or platinum, I should say, gemcitabine, and then platinum and pegylated liposomal doxorubicin. In the U.S., you can only use bevacizumab with carbogem and carbotaxol, which is different in Europe. We would like to use it with carbo and pegylated liposomal doxorubicin. The Calypso study compared carbo, I'll call it PLD from now on, to carbotaxol, and it was a non-inferiority study, and so carbo PLD was certainly not non-inferior. It looked a little better. So we like that regimen a lot because it's every 4 weeks, you don't lose your hair, there's no neuropathy, the hematologic toxicities are a little bit more, but it's really a preferable regimen. But in the US, you can't use Bev with it. And there's never been a comparison of carbogem to carbo PLD with bevacizumab. So we kind of have always said that they're equivalent. We kind of say, oh, they're probably all about the same in terms of efficacy. In this, it's not like this super fancy new drug study, but it's a very important study because it tells us they're actually not the same, and that carbo PLD Bev is better than carbogem Bev. And carbogem Bev is a good regimen, but it does have more hematologic toxicity. So it's a little bit harder to use, actually I think quite a bit harder to use than carbo PLD. So this, it was better by 4 months, and even in patients who'd seen bevacizumab previously, which in the US is a big issue, not a negative issue, but patients get in the front line. In Europe, it's only approved a lot of times in the front line. And so if you're going to be able to start using it in the second line, it was still superior, not as much, but still superior in that group.
Okay.
So this is just a really practical study that directly impacts patient care, agnostic to any biomarker or anything else you're doing. This is a very important kind of practical decision-making study that people go home from ESMO and you just change your practice. There's no new indication, just this is what you're going to do now. So I actually really like that study. I wish we can't do studies like that in the US anymore. I'm so glad that they get done other places, because I think that's practice changing. And that's what you want to do.
And it sounds like it answers a question that
that we all kind of go, which one should I use? And you kind of pick based on your comfort or toxicity, you still have to base it on prior toxicity of the patient. So sometimes you're picking something really based on what's toxicity-wise best for your patient, but all other things being equal, sometimes you just pick one. This gives you data to pick one, which is always superior to just guessing. So exactly. I think it's a really important study. Yeah. I'm proud of them for doing it.
These are great points. So now, looking at the 3 PARP inhibitors that we have now in the maintenance setting for ovarian cancer, what does the future hold for this class of agents?
Well, I think that there are so many exciting things coming in the next few years that it's really hard to answer that. I think right away we're going to see adoption of frontline incorporation of olaparib for BRCA patients. And that's going to unleash a whole series of questions. So number one, what percentage of those patients are now cured and never need another therapy? I want to know that. But a certain percentage of them are going to recur. And so when they recur and they're sensitive to platinum, again, do you reuse a PARP inhibitor? We have no idea. There's a study ongoing called OREO, which I hope gets done because we need to know if you've had a PARP inhibitor, does a PARP inhibitor ever work again? Or if you had a PARP inhibitor for 2 years and then didn't progress for 5 years versus you had a PARP for a year and you progressed, are there different types of people who should get retreatment with a PARP, or does it never make sense? We don't know. So that needs to be answered because the patients on SOLO 1 and the patients are going to start getting olaparib, there's going to be some of them who need this answer in the next few years. So that's going to be really one of the first things. Do you retreat with PARP? The data coming out probably next year, next year's going to be an exciting year, looks at PARP inhibitors beyond BRCA. So we have the Paola study, which hopefully will result next year. That's all comers, chemotherapy with bevacizumab, and then for the maintenance bevacizumab, one arm has olaparib and one arm does not. And that's a progression-free survival endpoint. And that will be the first study in PARP inhibitors to look at a biomarker agnostic endpoint first. So they're, at least as planned, this is an intention to treat population. If that's positive, meaningfully positive, then everybody's going to have PARP and bevacizumab in the front line. And then you're going to have to figure out, do the BRCA patients need the bevacizumab or not? Can they just get away with just olaparib? Paola does have BRCA patients, so we may be able to, because it's a stratification factor, we may be able to tell. They may not have needed it or not, but the control arm's bevacizumab, so that's going to be a question. If that's positive, is it overkill to give the BRCA patients 2 things? Everyone else probably needs both. You have PRIMA, which is the niraparib frontline study that's done and maturing, looking at switch maintenance niraparib. Also in an all-comer group, high-grade serous, high-grade endometrioid. They are collecting, of course, BRCA status, but they're looking at homologous recombination deficiency as their primary endpoint. Okay. And then would look at the whole group if that's positive. So it's a kind of intermediate endpoint. So that one's going to most likely will result at the end of the year. We'll see. And then Velia is veliparib, which is a PARP inhibitor we don't talk about quite a bit. It doesn't have an approval yet, unlike the other 3, but it's the only one really you can combine with full-dose chemotherapy. And so that's been evaluated in the Velia study, which is chemotherapy with veliparib maintenance, chemotherapy with placebo maintenance. And so likely that we'll get some either preliminary or maybe the primary endpoint for that next year. So I think that most of us think one of those is going to be positive. So I think that will expand use in the front line, and then the same questions about what happens when people recur are going to come up. Do you reuse a PARP? Do you go to bevacizumab? Because certainly if they had bevacizumab in the front line, there's nice data that says you can reuse it and it's still effective. So we know that answer. Mm-hmm. But then I think the field is wide open. And we are starting to see some additional agents come into testing now in this platinum sensitive space, looking at other targets of DNA, damage response, pathway, ATR inhibitors, WEE1 inhibitors, things of that nature, where if someone's already had both and they recur, maybe there's some room for some new agents. So I think we're going to have to start thinking about what we use in that space. And then the whole field of immunotherapy is, we don't really have data to comment on yet, other than the single agent data, which I'm just going to say is disappointing. It does show there's a signal, but not enough of one. However, if you combine it with PARPs, or you combine it with anti-angiogenics, or in some studies all three in the front line, does that convert more people to cure? That's sort of the story yet to be told. And those studies are all just launching, so I think we're years out from seeing that. But we should see results coming of the first immunotherapy frontline and platinum-resistant study, Javelin 100, Javelin 200. Those are both completed and maturing, and so we expect that we may see some preliminary results or final results from those in 2019 as well. So I think 2019 is going to be an interesting year for GYN cancers. I think we're going to get a little more confused before we get unconfused. But we're not confused about PARP in the front line for BRCA. That's a definite, yeah. Huh. So I think it's exciting finally to have some movement.
Yes, it sounds like it's going to be a year of a lot of excitement and hopefully some progression, good progression.
Big phase 3 studies resulting, well-designed trials. I think, let's see if they're positive. I don't know anything, but it's nice to have some trials resulting and see what we find.
Definitely.
Yeah.
Well, Dr. Moore, thank you so much for being here with us today, and congratulations on these really exciting studies coming out.
Yes.
Great.
All right.
Thank you.
Thank you.